Here we go. So page 1, the beginning is just the anatomy review. So we can go through that if you need to, but I would just say let's just keep going.
Yeah.
Okay, so on the other side, it talks about the origin of stuff. So do you know what UGIB, and LGIB mean?
No.
Upper gastrointestinal bleeding, lower gastrointestinal bleeding.
Okay.
Okay. Hemoptysis.
That's bloody spit.
Yeah, bloody throat, bloody sputum, or bloody vomiting, right?
Yeah.
Because remember, there was hemoptysis, which was spit or bloody sputum, and this one is hemoptymesis. So it's very similar. So hemoptysis is bloody sputum or spit, and this is bloody vomit.
Okay.
Very similar in spelling. It's very similar in how we say it. So it's
yeah.
hemoptymesis. Try saying that 3 times. Okay. Melina. You still there?
I'm here.
Oh, okay, Addie's with us. Okay. Hello, Adriano.
Hi, how are you?
How are you?
Doing well. Whoa.
Yeah, I gotta stay on the slides or it does some weird thing to your guys' screen. Okay, so we're going through these just on the first slide. We're going through the origin stuff. So we talked about hematemesis. Now we're talking about melena. So what's melena? Does anybody know?
I don't actually. You guys are now ahead of us.
So this will be good for you. So
yeah.
So what I've done is I put together diseases by location, and they don't act one-to-one. That the one side, the left side, is just a review of the GI system in order that things come. So your mouth, your voice box, your esophagus, stomach, liver, pancreas, gallbladder, small intestine, large intestine, rectum, anus. Okay, that's like flowing through the whole system. Okay, then origin. So UGIB and LGIB. So Addison, what do those mean again? So Addie can hear them, or Adrian can hear them.
Upper
gastrointestinal bleed.
Okay, upper gastrointestinal bleed, and then lower.
Lower gastrointestinal bleed, and then we talked about so there's hemoptysis, which is bloody sputum. Hematemesis is bloody vomit.
Yeah.
And we'll get into a little bit more details on those in a minute. And then melena is the other end. It's bloody poop. It's bloody defecation.
Yeah.
No, that's not your best friend's first name. It's bloody poop.
Bloody poop. Okay.
Okay. IBS is like irritable bowel syndrome, Crohn's, ulcerative
colitis,
colorectal cancer, cirrhosis, viral hepatitis, pancreatitis, and then cholecystitis. And we're going to kind of go through all these. Those are the major diseases that we got going on.
Okay.
So next page, GERD. And GERD is gastroesophageal reflux disease. Does anybody tell me what this means?
Can anybody tell you what? I'm sorry, you cut off.
Tell me what it means.
Oh, gastroesophageal. So it's the stomach and the esophagus.
Yep, that is correct.
Yeah, and so what it means is that we get the stomach acid that comes up into the esophagus because the sphincter doesn't close properly.
There it is. That's it. So, yep, it's because the sphincter's not closing properly. It's allowing gastric juices and acid to flow back into the esophagus, and it's irritating the esophagus. That's the pathology. Okay.
Okay.
So can anybody tell me the signs and symptoms?
Well, there's like a burning sensation. There's pain, especially if they're laying down, or like reclining or lying down.
Okay, so you guys got it.
The most.
Okay, so there's the two reasons. Many patients self-medicate to relieve the heartburn associated with this disease, but is only temporary fix. If this practice continues, the patient will develop electrolyte imbalances. Okay, because
Right.
of magnesium and Tums and those different antacids, they have magnesium, calcium, potassium in them. So
Yeah.
they'll start to get elevated levels with all the associated abnormalities with it. Okay,
Yeah.
pain worse when lying down, elevate head during sleep. Number 3 is the key one. So Addison, read number 3 for us.
Pain mimics heart attack. Teach patient to assume it's heart attack and get emergency care.
There you go. So go visit Addison in the ER if you're getting chest pain like this, from even if it's GERD, because the worst case scenario is it's not GERD, it's a straight up heart attack, and you'll die.
Better safe than sorry, right?
Better to receive a higher level of care and be told that you don't need it than to not get it and die.
Absolutely.
Okay. So respiratory signs and symptoms can develop due to esophageal damage. So throat cancer, you know, all that stuff. Those are the other things that can happen. We can also occlude the airway. Acids can get up into the esophagus and irritate the larynx, and you can start to do things that can damage the esophagus and the larynx, which means that you won't be able to breathe.
Right.
So those are the other things. Okay, risk factors. Anybody other risk factors? Addison, give me 2 risk factors for GERD.
Obesity and alcohol.
So yeah, so I made a joke. So Adriana, I made a joke in our class on Tuesday that there are 4 risk factors for every single thing we've ever talked about in this class. Not just today, but everything. Smoking, being obese, drinking, and having a bad attitude are all the reasons that we get sick and everything happens to us.
Especially having a bad attitude.
Yeah, no, I know. I was being a smart ass. But no, so smoking and drinking, alcohol are 2 of the big reasons for everything. Being obese and diabetes are the other 2 that we see with everything that we have.
Yeah. Diabetes is everywhere too.
So the risk factors from the book, from the notes: obesity, I call that fat camp disease. Pregnancy.
Yeah, pregnancy is another one.
Yep, smoking, and then hiatal hernia. So
The hiatus.
yep, that's we're going to talk about the next really deep. We're going to get more detailed about it. Fatty foods, alcohol, and chocolate. And then there are 2 kinds of treatments for this. What's the first kind of treatment? 2 general treatments that we use.
Antacid, acid suppressing medications. So antacids, basically.
Yeah, so there's I put on the notes. Our notes don't talk about it from the class, but I put it on the notes when I built this. There's non-invasive treatments and there's an invasive treatment. So there's surgery is the invasive treatment, and then the non-invasive treatment are all lifestyle change treatments, things that don't require us to get surgery.
Yes.
So stopping smoking, don't drink caffeine, check for a gluten allergy, high protein diet, sleep with your head elevated, and then elevate your head 2 to 3 hours after meals. And then obviously invasive surgery is to get the hiatal hernia and your weak sphincter, your cardiac sphincter fixed, and that will also stop esophageal reflux disease.
Wow, I didn't even know that there was a surgery for that you could actually get surgery to fix the sphincter.
Yep, there is a surgery for this. And then obviously the blue bottom comment is just a note that when a patient does receive emergency care thinking that their GERD is a heart attack, the way that nurses that we treat this, or we determine the difference, is we give them an antacid with the larynx Novocaine. It deadens any pain. If they get relief from that, then we know it's definitely cardiac based. If there's no relief from that, if they get relief, it's definitely GERD. If they don't get any relief, it's cardiac. And that's these is cardiac cocktail, as well as cardiac tests. So blood pressure, pulse ox. We're going to do those tests to determine. I mean, if they have an altered EKG and a low pulse ox associated with this disease, that's probably a pretty good indicator it's not GERD and it's cardiac based.
Right.
So, okay, we good? Can I keep going?
Yeah.
Yep.
Okay, page 2, hiatal hernia. Somebody tell me what a hiatal hernia is.
Hiatal hernia. Says pathophysiology, protrusion of the upper part of the stomach through the diaphragm into the thorax, causing congestion of blood flow and ischemia. The pressure weakens the opening that the esophagus enters through the diaphragm at the hiatus of the stomach, which gives the name hiatal hernia. Exact cause is unknown. The condition may be due to a weakening of the support tissue that allows the diaphragm ring to widen and allows stomach tissue to rise up through it. Yep.
Okay, so instead of talking about the risk factors that are the same between these, let's identify the risk factors that are different.
Okay.
So we know smoking and alcohol and being fat, those things are things that all we think are risk factors associated with this disease. But what are some things that aren't the same between GERD and hiatal hernia? What makes them different?
Over 50 years, it says here.
Age is a discriminator. So people who are over 50 are more likely to have a hiatal hernia than someone who's younger. That's not saying that someone who's younger can't get it, but it is a lot more of an indicator in an older individual. Okay.
Training and like eating disorders.
Yep. So someone who has an eating disorder or a vomiting-based disease process, or someone who trains with weights, who's a CrossFit nut, those people are going to be a little bit more apt to get this. Does anybody know why?
Because they bear down? Is that
bearing down and weight training?
Carrying heavy weights and
bearing
down.
But why would throwing up or having a vomiting disease or an eating disorder cause us to get this more?
Does the acid weaken your muscles?
And there's Sandra. Everyone let's say hello.
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 So this is what it's like with one person on here. But yeah, so not only so we're exercising our esophagus in a certain way, we're actually asking our stomach to throw up. So instead of going down, it's forcing things back up. And so you're getting a weird muscle action at the diaphragm, as well as the accessory muscles in your lungs. So your intercostal muscles to get it to do that. And that's not normal. You keep doing that, there's always a chance you're going to perforate, or not perforate. You're going to force elements of the stomach back up. Okay. So that's one of the, and then obviously damaging the esophagus, damaging the esophageal tissues around the opening near the stomach is going to weaken them and allow them to move.
So this is for people with bulimia, right?
So anybody who has, so again, I think Sandra and I talked earlier at 5. It's really easy to say just bulimia, but I think the key thing is people who are vomiting uncontrollably. So say somebody who had dysentery, a vomiting-based disease that's causing people to, or they got food poisoning where they're vomiting a lot. They'd be apt to get this, but clearly someone who is forcing themselves to vomit because of an eating disorder or a psychological issue, then yes. But I like to focus more on the vomiting aspect because I think anybody who has vomiting disorders.
When it says habitual, because habitual is something that you do like on a regular basis.
Yeah, it's very consistent.
Somebody who's sick is not habitually vomiting, but I see what you mean. So if somebody who's very sick and is vomiting forcefully,
a lot,
develop the same.
They could be potentially getting this again. Like I said, obviously eating disorders is a little bit more consistent. They're vomiting more consistently, but again, I wouldn't rule it out if somebody had been really, really sick, say stomach sick, had been throwing a lot, and they started exhibiting some of this. It wouldn't be a shocker.
Right.
Okay. So I think we got them all the weird stuff. And then so do we ever find hiatal hernias by themselves? How do doctors normally find this?
Probably when looking or checking for other.
Yes, absolutely.
Of other things.
GERD. So they're going to have GERD. They go in for that heartburn. The doctor scopes them, or we do an X-ray, and then we find it. Oh, there's a hiatal hernia. Wham bam. Thank you, ma'am. When we find it, so that's a giveaway on this one. Okay. Also remember that when you have a hiatal hernia, your esophageal sphincter or your cardiac sphincter is actually not in line with the esophagus anymore, which also weakens this. So instead of having the diaphragm and the esophageal sphincter together, now it's sitting above it and it's weaker, and the diaphragm's not assisting in closing it off.
Yeah.
Okay, so what are some of the ways that we treat this?
Anyone?
Anyone? Bueller?
Yeah, I can have it right here, so I can say it's acid suppressing medication and surgery if severe enough.
So again, the treatment for this is very similar to GERD. They're going to be very, very similar how we treat them.
Mm-hmm.
Okay, next up, peptic ulcers. Yay, I'm so excited. Okay,
that's the one that H. pylori.
Yep. So yeah, so peptic ulcers, by definition, what is the pathology going on with peptic ulcers?
We have
I know Sandra knows it. Sandra, what's the pathology of peptic ulcers? Did we lose somebody? Oh,
not sure.
And I don't know where she's at. Hold on. Sandra. Okay, Adriano. Okay, we're all here. Okay. We're fine. Gonna be okay. Okay. I'm back. I'm gonna go back to the slides. So I have the slides up. I can't see guys' beautiful smiling faces. Okay, so peptic ulcers have to do with a breakdown of the lining of the stomach. So now we're out of the esophagus, and now we're down in the stomach and the duodenum of the small intestine. And it is caused primarily by what?
H. pylori.
Yep, H. pylori. Okay, H. pylori is what?
It's a bacteria. I actually have it, sadly.
Well, I'm sorry to hear that.
It's a pain. I know, it's a pain. You have to keep it under control, and it's really hard to kill. Really hard to kill.
H. pylori is the primary thing that causes this. So some of the other reasons that people get this is it can develop due to burn trauma, head injury, and critically ill patients can get it as well. In addition, those are the other reasons that this develops.
And there's also smoking, it says here.
Yeah.
After smoking, alcohol, well, that's a surprise. And NSAIDs.
NSAIDs is the new key one here.
Those are all risk factors.
Okay. So signs and symptoms is just basically chest pain.
Dull, achy, or sharp.
So again, so the difference between GERD develops between 30 and 60 minutes after eating. But peptic ulcers develop 2 hours after eating. So you're going to get similar pain, but they're going to be after eating, 2 hours after eating.
Mm-hmm.
Okay, and then it says when the stomach is emptied.
So, question.
Yes.
What's the difference between like a peptic ulcer and just like a regular ulcer? Is it just because of that specific bacteria?
So, yeah. So if you look on page number 4, or excuse me, page number 3 of the notes, it talks about 3 different kinds of ulcers: duodenal, gastric, and stress. And so that is a great question. I don't want to get into that necessarily per se tonight. I'm going to table that question for the next study group, so we can dig a little bit more deeper into this. Right now, I just want to cover the generals about peptic ulcers.
Okay.
I think what you're asking, Addison, is they're very similar. I think what you're talking about is stress ulcers, and then there's gastric and duodenal ulcers. I think stress ulcers, they're all considered peptic ulcers, because peptic ulcers by definition are just a breakdown of the lining of the stomach wall, and it's allowing gastric juices and acid and food particles to squeeze out into the cavity outside the stomach.
Okay.
Is that a better answer without answering your question?
Yeah.
Okay. I'm still working through how to get an answer as well.
No, that's good. I just didn't know if it was classified as like a gastric or stress, or if it was like just kind of.
Yeah, I think what specifically we were asking if that's a stress ulcer.
The same thing.
Yeah, they're all classed as peptic ulcers, and so I'm not going to dig in. I'm going to save that for tomorrow. I'm going to work through this spreadsheet, and then we'll dig into it a little bit deeper tomorrow.
Okay.
what happens with this peptic ulcer disease, it's actually the H. pylori is one of the biggest culprits, is that it basically destroys the lining of the stomach. Okay. So that's why the stomach, then, because the lining of the stomach is the type of cells that are able to endure that very acidic environment in the stomach. And so when they're destroyed, then the less able to survive cells underneath get really damaged by the acid.
Well, and we know what is the reason that the stomach is able to handle the acidic environment? Do we know why? It's lined with a very, very special kind of mucus.
Right. And the cells that line the stomach produce that mucus.
Yeah, they produce mucus, and so the mucus that lines it, so H. pylori specifically is attacking the ability of those cells to create mucus. Then when the mucus is removed, then the stomach acid can actually burn through the epithelial cells that are present there and leak out.
Mm-hmm.
Okay, one of the key things about peptic ulcers, though, is if we can remove the H. pylori from the stomach, that bacterial infection, if we can remove that, then the stomach has a really, really, really strong defense mechanism, and the stomach will repair itself very, very quickly and easily. So once treatment begins, people usually respond really, really quickly to treatment, and they get back to normal and they feel better.
Right. It's because the stomach cells, the cells that line the stomach are one of those that replace themselves very quickly, just like the throat and the stomach, all the ones that get damaged by chemotherapy, all the fast, I guess, what's the word I'm looking for? Fast reproducing cells.
Yeah, they just have a fast reproductive process, and they replace very, very quickly.
Yeah, and so that's why they can fix themselves. If you can remove the offending agent, then you can get better.
Yeah, which is awesome that they do that. Okay, so moving along, remember the three red words here. This can develop into anemia, profuse bleeding, and stomach cancer. So you're not gonna just automatically develop stomach cancer. Usually, you're gonna usually get peptic ulcers, and then it's gonna get aggravated to the point that you develop stomach cancer.
Yes.
Okay. So again, some of the things that we've talked about in the past that we struggle with, at least I do, is tests for the different disease processes. So in peptic ulcers, there's a bunch of tests we can do. CBC, hematocrit and hemoglobin levels. So why would a CBC and hematocrit and hemoglobin levels be important for peptic ulcers? Why would we use that as the test for it?
Because we want to see if there's a possibility of bleeding. Bleeding anywhere in the body, but if we're looking at GERD symptoms and that kind of stuff, we want to see if the stomach is having bleeding issues, which would show up as low red blood cell count, or maybe
that was the key thing. That was the thing I wanted to get to. So Addison, I know you and I have talked about that at least once before. That would be the indicator that you have some internal bleeding going on in the stomach, even if there's no throwing up in the blood, or on an occult blood test, we check if we see the CBC count going down, our red blood cell count going down in our CBCs, or a diminished hematocrit or hemoglobin level, then we've got bleeding going on, and we know to investigate further.
Yeah,
and that could potentially be a test question, right? So we get a test question. Hey, Miss Jones comes in to the hospital complaining of chest pain. She has a normal EKG, normal blood pressure, normal pulse. She gets relief from the cardiac cocktail, but her CBC, red blood cell count, is diminished. What's going on with her?
And we know she has gastrointestinal bleeding.
She's got some GI bleeding going on somewhere. Now we just need to understand if it's upper or lower. Is she bleeding from her esophagus out into her stomach and out, or is she bleeding lower in her intestines into the rectum and the colon, and crapping out the blood? And then we're gonna do tests to figure that out.
Wouldn't you kind of be able to see though, because based on if she's throwing up blood or pooping it out?
Well, absolutely. If someone's directly throwing up blood, a lot of times we're gonna see it. And there's two words for that, right? In hema And hematemesis.
Hematemesis.
Two kinds of red blood in that. You're going to have red, just real red blood coming out as vomit, or we can have the ground up coffee ground blood throw up.
Yeah.
You know the difference? Why they're different?
I think I do.
The red one is closer to
the mouth.
Yeah.
Okay. And when we have red blood coming out of the poop that's bright red, where's that at? What kind of disease process would kind of have red blood coming out the rectum? What would cause that?
Something like hemorrhoids.
Thank you. It's going to be hemorrhoid based or anal fissure based.
If it's coffee ground colored, does it always mean that it's partially digested, or does it just mean that it's farther away and it's turned brown with age?
So yeah, I think anytime that we see coffee ground color and coffee ground substance coming out the mouth, it means it's been in the stomach long enough for it to digest. I think you can see that melena, that black tarry stool, blood in the stool, and that means that it started higher up in the small intestine. There's still a disease. There's still been a digestive process, but the digestive process didn't happen in the stomach. It happened in the small intestine and the large intestine. But we're still going to see a digestive process if it's further away from the opening. And now it's just determining which opening. If it comes out the mouth, it's going to be that coffee ground substance, meaning it was in the stomach. If we get that black, nasty, melony stool, that means it was higher up in the intestines, but it's still been digested blood. And now it's coming out the rectum as part of the stool sample or part of their stool. Did that answer? Did we kind of beat that to death? What's going on with those?
Yep.
Okay, so just really quickly hitting all these tests, so we can see an EGB, so an esophageal gastroduodenal scope. So if we see the scope, the scopy or scope, what does that word mean in anything that we do in medicine?
We're putting.
It means what? Somebody throw it out.
I mean, does the scope refer to the camera part, like the way that you're looking?
Yeah.
Or does it refer to the inserting it?
Again, scopy or scope just means to observe. Like, that's by definition. Whether we look with our own eyes or we look with the camera, we're scoping them. Okay. Traditionally, though, now in today's medicine, we determine scoping to the camera's been inserted. Because I don't know about you, my eyes aren't very good. I can't look down somebody's esophagus into their stomach, right? I just can't physically do that.
I don't think anyone can.
We do that with a camera, but I do know, because I have actually done this to somebody, we call inserting an endotracheal tube on the trachea side, the breathing side. We use a device called a laryngoscope, which is just a flat piece of metal we stick in there. It just opens their airway so we can physically, with our eye, look down in there. But it's a tool that we use to scope the throat, to open up, to move the epiglottis out of the way, to physically look down the trachea into the windpipe. In the case of GI, we're going to use an endoscopy, which is a pipe with a camera on the end of it to do the scoping.
Makes sense.
So there we go. That's what just beating it to death. Scope means to observe. We're going to actually look. And whether it's with a camera or with our naked eye, we're just going to have a look. Okay. H. pylori blood test. We're just going to look for H. pylori bacteria in their blood. And then we're going to biopsy. Who knows what biopsy, the tissue of the stomach, means?
Taking a sample of the tissue in the stomach so we can...
we're going to physically cut them open with a knife. We're going to get in there and we're going to take a sample of the diseased tissue and we're going to look at it. We're going to test it away from the body and see what's going on with it.
Just a side note, there's a much easier and less painful way to do it. They actually have you blow into a balloon.
What?
Basically just blow the balloons. That's what they did the test for me. I blew 2 balloons and they sent those out to test them. And they basically just used the air that I blew into the balloons to check for H. pylori.
That is really cool. I would have never thought of that.
Isn't that awesome?
And now I'm glad that Adriana is in our study group because I would have never known that.
Yep. That was the only fun part about that disease.
So Adriana, since you actually have H. pylori, will you please explain to us the treatment for this disease process?
Yeah, they do give you 2 medications. There are 2 types of antibiotics that work together. and it's horrible. It makes you dizzy. It makes you nauseous. It's just like a really not a fun thing to do. It's like a 2-week course. You have to finish the thing completely. And if you don't finish it, then most likely it's just going to come back. And the sad part is that even if you finish it, you might not kill them all. And if you don't kill them all, they just reproduce and come back.
Well, how exciting is that? Aren't we all excited to get peptic ulcers?
Not fun.
Okay, guys, one of the things in the notes it talks about cauterizing an upper GI bleed as they scope. As they insert the scope, they can cauterize. Does anybody know what cauterizing means?
Burning, basically, to like close the area that's to burn the opening shut. So anytime you hear the word cauterization, it just means to burn it closed. And they usually use electricity for that, right?
Yeah, they could. Yeah, traditionally it's like an arc welder looking thing. It sends an electric current between two probes. They touch the spot and it pulls them together and burns them shut.
Mm-hmm.
Okay, so moving right along, page 3. Just know the 3 types of ulcers are duodenal, gastric, and stress. And we talked earlier, Sandra and I, about duodenal. So, Sandra, what does duodenal mean?
Duodenal is the first part of the small intestine, like just the first few inches.
Yep, it's the first like 6 to 8 inches of the small intestine near the stomach. So the first area the stomach empties into is the duodenal area. Then gastric is obviously the stomach, and then stress is stress, right? And then the specific areas that we're going to talk about with these different kinds of ulcers: age, gender, stress factor, hyperacidity, ulcerogenetic drugs, associated gastritis, if bacterial infection is present, pain, and hemorrhaging, if they're hemorrhaging or not. Okay, that's all I'm saying about that particular part of the slides today. So wink, wink. If everybody will kind of review those different areas, so when we talk about these again, we'll all be a little bit more spun up on them. We can move forward together as a group. So signs of GI bleed. Okay, well, obviously, signs of GI bleed. If you're bleeding from the upper respiratory tract, where is that going to present from?
Vomiting.
Upper GI bleeds present how? Where do they come? How do they come out? Come out of the mouth. Lower GI bleeds come out how?
The other end.
The anus, right? I know what this is. This is part of the fun class of anatomy and physiology and patho. We get to say anus, and it's okay.
Just like the base.
Just base. Okay. So occult bleeding and overt bleeding. Who can tell me what occult means again?
It's when you cannot visibly see the blood. So it's there, but you cannot see it with the naked eye.
So this is going to sound really stupid. Anytime I think of occult, I think of the Pink Panther. He's sneaking around. Right?
Yep.
He's there, but he's sneaking around. So he sneaks. Da-da, 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 da-da. You know, we're overtly bleeding. It's something that we're going to have to go looking for, like private eye style. Okay? Overt bleeding just means that we can physically see it in the sample. Whether it's vomit or stool, we can physically see it. Okay?
Think shameless.
Hematemesis.
For the world to see.
I think I just said that word right. Hematemesis. I think I said it right. Does that sound right?
Oh, yeah.
Hematemesis. Okay, let's all say it together now that I've said it right. Hematemesis. 1, 2, 3.
Hematemesis.
There we go. Edrano, say it.
Hematemesis.
Hematemesis. It's only taken me 3 hours to learn to say that word right.
It's a hard one. So hema for blood, and emesis is vomiting. That's you get antiemetics when you're vomiting too much and they want to stop the vomiting.
So what's the word for bloody sputum, the bloody spit?
Oh yeah, hemoptysis or something like that.
This is bloody spit. Hematemesis is bloody vomit.
Bloody vomit.
So I'm going to play a game. I'm going to say spit, bloody spit, and you're going to say the word. And I'm going to say bloody vomit. You're going to say the word, but I'm not going to tell you which one I'm going to say first. You guys ready, ladies? You ready?
Ready.
So bloody vomit.
Hematemesis.
Bloody spit.
Hemoptysis. That one is harder to say.
That is exactly why I just did that. So it might take us a little bit to get good at saying those words off a cuff, right? We might have to practice that a little bit. Okay. So bright red blood means it's closer to the mouth, and then darker coffee ground blood is more deeper in the stomach. Which blood is more dangerous in the hospital as nurses? Which one are we going to be more concerned about?
I would probably say the coffee ground.
So in the upper respiratory bleeding and lower respiratory bleeding, they're opposite. In upper respiratory bleeding, bright red non-digested blood is more dangerous. It's more of an emergency. So, Sandra, can you tell us why that's more of an emergency in upper respiratory bleeding?
It's because it shows that the bleed is close to the mouth, and if you think of what is close to the mouth, then it could block the airway.
Thank you. That was the word. So as we get bleeding higher in the esophagus, we get closer to our trachea and to our epiglottis and our voice box. If we start getting bleeding in there, it means we could have inflammation and other damage going on, which could what? Block the airway, and now we have a lot more serious situation going on.
ABCs.
ABCs. So thank you, Sandra, for explaining that to everyone else. And then, so coffee ground blood that's lower in the stomach, it means that the bleeding is lower, potentially. It's flowing into the stomach, being digested, and then being regurgitated. It's being vomited out. So it's still serious, but it's not as serious as bright red sputum and vomiting from the esophagus.
Got it.
We good? Okay. So if hematemesis is bloody vomit, then melena is what?
The bloody poop.
It's black, nasty, stinky, dirty, digested, poopy blood. Yay. How exciting is that?
Sounds nasty.
Their first melena at the hospital? Raise their hand. I'm so excited for my first opportunity to see this. Okay. And then hematoschisia is a different word. That means red blood near the anus. And we talked about what causes that kind of bleeding.
Hemorrhoids.
Yep, hemorrhoid or anal fissures. So damage near the rectal structures is going to cause that bright red blood. And there's nothing around that that's really, really life-threatening. And so that's why it's less of an issue, where internal bleeding up in the intestines is a lot more serious, because that's a pretty significant disease process that they're bleeding up in there. Good? Questions we good so far, everybody?
Yep.
Okay, moving right along. So irritable bowel. Ooh, another one of my favorites.
IBS.
Okay, so so an irritable bowel, we're moving. So we started in the esophagus, we moved to the stomach. So now where are we at? Moving down the body. What are we talking about now?
Now the lower intestine, or the small intestine and the large intestine, right?
So yeah, so the pain process here has moved from the chest or behind the heart. Now that's moved down into the abdominal cavity. It's moved down to the intestines. So that's the number one difference between irritable bowel and GERD and peptic ulcers and hiatal hernia. Those diseases, the pain is up in the chest, and now where the pain is associated with this is down actually in the intestines. So again, test question. I have two patients. One patient comes in with chest pain. What are the diseases or the processes that are going on that I'm going to look for in that person? If they have chest pain, what's the number one thing I'm going to assume that it is if they have chest pain?
Heart attack or something like
cardiac related. Once I discriminate the cardiac pain away through testing, then I'm going to assume that chest pain or upper chest pain is going to be associated with what?
The stomach.
Yep, GERD, stomach, or esophageal issues. But if they have pain associated down in their abdomen, down below their diaphragm, there's only a few disease processes that it can be down there. Hepatitis, irritable bowel syndrome, colitis, colorectal cancer. Does that make sense? And it's down the system, and that's where the pain is going to be associated, and then it's going to be relative to where it's located. Okay, so IBS.
I had a patient today with rectal cancer.
Oh, really? Can you share any details? Can you share with the group?
He was really nice. He was my nicest patient.
So, in addition to having cancer of the colon, he was very friendly.
Yep, it taught him something apparently.
Oh, you taught him something?
No, the cancer.
Oh, it taught him to
Nice.
appreciate his life, huh?
Yep.
Okay, so the pathology of IBS is considered functional gastrointestinal disorder, meaning symptoms are caused by changes in how the GI tract works. So everything is still working. They're just seeing changes that are causing the pain. Okay. So this one has a really, really, really weird sign and symptom. Does anybody know what it is?
Symptom, you said?
This one has a mental component.
Oh yeah.
Ooh.
This is weird because it's got this weird like mental component.
And in class, didn't she say that that they weren't sure? Like it kind of went both ways. Like the bowel could maybe the bowels are causing some of the mental problems, and maybe the mental problems are causing some of the gut issues, and it kind of can go back and forth, and they're not really sure. They don't understand it necessarily. Isn't that what she said?
Yeah, she was talking about how they kind of flow both ways. That you could get irritable bowel syndrome, which could exacerbate a mental disorder. I mean, obviously, if you're having if you're having pain in your abdomen and in your stomach, I don't know about anybody else, but that really pisses me off. It makes me really angry and anxious.
Hard to be happy when you're in pain, right?
Yeah, and then vice versa, like having been exposed to post-traumatic stress and been in combat for a year, I know that I didn't crap as good when that was going on.
Anxiety, when I had anxiety and I was nauseous and like had all these, I didn't even know it was like a symptom of anxiety. I didn't know that's what I was having. Isn't that weird?
Yeah. So again, I think you're exactly right, Sandra, bringing that up. That it could present either way, right? So your anxiety can elevate your gastric issues, or vice versa. Your gastric issues can feed over into the rest of your life and make you an angry, mean, crazy person.
Yeah, it makes sense that anxiety, like mental anxiety, is going to cause all kinds of havocs with your body, right? But especially with the stomach, where you feel nauseous and want to vomit, and then your stomach is all upset and
crazy. I can't wait. I mean, she talked about how this is a new, like, lots of science is being done about this. I can't wait to see what they figure out with that.
They're getting into the biome of the stomach, into the intestines. They're talking about like oh shoot, I just forgot it what it's called. So Audra, when you go to class on Thursday, you're gonna be. This is actually she has a pretty good discussion about this, and she adds some stuff to it that's actually pretty cool.
All right, I'm looking forward to it.
So I want to hit a couple of the signs and symptoms, just the basic stuff that makes this a little bit different than everything else. So just remember, this is persistent and recurrent. It's going to keep coming back. Okay. There's altered bowel function with or without GI damage. So you can have this happen and not have long-term recurring damage, or you can have this happen and you can start to see gastrointestinal damage in the system. Okay. They fart, flatulence, they get bloated, they're going to have nausea, they're going to have anorexia. Does anybody know what the word anorexia means away from an eating disorder?
No hunger, basically, right?
Anorexia by definition means lack of hunger. It's nervosa, the anorexia nervosa, that's that second word that associates it to an abnormal eating disorder issue. So just anorexia itself means the absence of eating. You're just not hungry.
Is it the absence of eating, or is there just no appetite?
I think it could go either way, right? Like, I think anorexia can roll either way. You can have either loss of appetite, or it's just or like you get busy. I don't know about the rest of you guys. When I get at work and I get busy, I can go 8 hours without eating.
Yeah, and you forget that you haven't eaten, right? Until you're not so busy that you go like, oh my goodness, I'm starving.
So I think Sandra, I think either definition would work for anorexia.
Yeah, and I always remember about the cancer, like, one of the signs and symptoms of like the chemotherapy, that you get the sores in the mouth, and that causes anorexia too, because it's painful to eat, so people just don't want to eat. plus they also lose the taste buds and all that kind of stuff. It just makes them not even interested in food.
And we also see anorexic in like cancer patients, right?
Right.
They may have nothing going on with their GI issues, but they start to get chemo and radiation, and a lot of chemo and radiation people, or those that are on serious antibiotic treatments, because of the antibiotics and the immunosuppressive features of those treatment patterns and those disease processes, we see a lot of those people not wanting to eat. So I think we hit that. I think we killed that. So constipation and diarrhea, yes. 2 new awesome words. Both just bring up awesome images to our mind. And then last and certainly not least,
bloating and flatulence.
Ooh, bloating, flatulence, diarrhea, and constipation. Ooh, so exciting. So IBS accompanies anxiety and depression. And that's so let's move on. Okay, guys. So we got like basically 10 more minutes. In the interest of getting a good review of the whole slide deck and not miss the rest of it, I want to quickly just roll through the rest of the disease processes, just cover the pathology, and then as we meet again, we'll start to dig down more into the signs and symptoms and into the treatments. Is that cool? Everybody okay with that?
Sounds good to me.
Okay. So irritable bowel syndrome. Okay. Colorectal cancer. Okay. And then Crohn's disease.
Crohn's.
So I don't know why colorectal cancer is in there and then Crohn's, but so who knows? Who can tell me something about Crohn's disease? What's special about Crohn's?
It's an autoimmune
based, right? Autoimmune based, and it causes people to have really, really weird craps.
Crohn's and
Yep, ulcerative colitis is the other one.
Ulcerative colitis.
Ulcerative colitis and
also autoimmune.
Are both autoimmune based. Okay, so those two there on a test question. If you get somebody who comes into the hospital, so Susie Smith, 24-year-old female, comes in, is having weird craps, but no other signs and symptoms, and you determine that she's having an autoimmune reaction, right? That's the giveaway that it's Crohn's or ulcerative colitis. Okay, we good with that? Anybody have any issues with those two? Okay, we'll talk more about those later. Okay, colorectal cancer is the next one. So does anybody know anything about colorectal cancer right now?
Has a lot of risk factors.
There are a ton of risk factors. Let's go through them really quickly. The colorectal cancer risk factors really quickly. So age, 50 years or older. Gender, this affects people. It affects men greater than women. Race, Black and Caucasian races are more affected by colorectal cancer than say Asian or Hispanic. Family history. So if you have a previous family history of colorectal cancer, you're 25% more likely to develop colorectal cancer in yourself. Okay, meds for Crohn's and ulcerative colitis. So autoimmune medicines that we're using for ulcerative colitis and Crohn's can also elevate your risk for colorectal cancer. Diet. Basically, if you're eating the American diet, you're going to get colorectal cancer.
Chris, the medical HX, that's medical history, right?
Oh, I'm sorry. Yes, medical history.
So medical history of Crohn's disease or ulcerative colitis, there's more of a chance to have or develop colorectal cancer.
So yeah, if you have ulcerative colitis and Crohn's disease, you have a 20% higher chance of getting Crohn's or colorectal cancer.
Colorectal.
So I apologize. Thank you. HX means history. PX means like patient, and then DX is like drugs. Sorry, ladies, I didn't mean to throw us off.
No worries.
My personal favorite fat camp, smoking, alcohol.
Yep.
Diabetes.
Not surprising.
No, it's obesity, lack of exercise, smoking, and alcohol consumption for colorectal cancer. Okay, we cool?
Yep.
We kind of touched on colorectal cancer, Crohn's, and ulcerative colitis. Page number 7. Okay, we're talking specifically the general hepatic pathologies. So can anybody tell me any diseases associated with the hepatic system? Anything? So what do we get if we drink too much alcohol and our body can't purge alcohol? What happens to
fatty liver? Is that fatty liver?
Well, cirrhosis is specifically associated with alcohol consumption, right?
Right.
So cirrhosis is one of them. One of the other things about the hepatic pathology that's very, very similar to renal pathology is prehepatic syndrome, intrahepatic syndrome, and posthepatic syndrome. So can anybody tell me what intrahepatic would mean?
Those aren't syndromes, are they?
Well, they're like diseases. Where would those processes be happening?
Right. It's just talking about like how it can happen either before the portal vein or inside the liver or after it flows out.
That was really only the direction I was going with that. That is a similarity between our kidney and our liver.
Yeah. We have pre-renal, intrarenal, and post-renal. So that is very similar.
Yeah, so that's just a way to associate these. That if so, for example, we have a diminished blood flow to the kidney, what kind of disease process is that going to be?
Prehepatic.
That's prehepatic. Thank you. If we have a blockage of flow out of the kidney, back to the beginning, that would be what?
Post-hepatic.
Post-hepatic, and then obviously, if we're having any kind of damage to the cells in or the blood flow within the kidney itself, it's going to be intrahepatic. Yay! So excited. Okay, so there is an acronym here that we want to probably start putting to memory. People drink so much. Okay, so under A, or excuse me, under P, there's 3 ABC. So produce ABC. So albumin, bile, and coagulation factors. Who knows what albumin is?
That's a protein.
So
The plasma protein.
Yep. What's bile? Hey, Addison, do you know what bile is?
It's the oh gosh, my cough. It's the thing that makes, isn't it like let me think.
You're okay.
No, it has to do. I mean, helps, or I guess it makes people's skin turn yellow.
Well, yeah, that's jaundice, right? So if we have damage to the kidney, we have jaundice, and that's because of bile buildup.
Yeah. So bile is.
It's a digestive enzyme. That's what bile actually is, what it does.
And it carries the bilirubin, which is the byproduct of blood breakdown. So when the blood is being cleaned and they're destroying the old cells and stuff like that, the bilirubin is in the blood, and this bile attaches itself to it and takes it out.
Takes it to the kidneys, right, where it becomes part of urine and we piss it off.
Right.
And last but not least, coagulation factors. Sandra, please explain to us the coagulation factors associated with the liver.
Coagulation factors. Do they make it? They produce it, right? They produce platelets?
There's 2 parts to this. Platelets are produced where? Who knows where the platelets are produced?
In the bone marrow.
Bone marrow is where the platelets are produced. But platelets by themselves do not function to clot blood. They have other factors which come from the liver called clotting factors, and those come from the liver. So platelets, in addition to the clotting factors from the liver, are platelets from the bone marrow, in addition to the clotting factors from the liver, actually produce blood clots in our blood when we start to hemorrhage. So are we good? Everybody good with that?
Mm-hmm.
Okay.
Yep.
Detoxes is D, stores glycogen is S, and metabolism of protein is M. So what was the acronym? One more time.
People
drink so much.
People drink so much. I am not one of those people because I don't drink so much.
I want to be one of those people. No, just kidding.
I would love to just kick back, no, I'm teasing. I've actually never had the desire to drink. It's never been something I've ever wanted to do. Okay.
Certainly not after this class.
Especially not after this class. I don't want to breathe, pee, drink, or poop in this class because every time I learn anything, you're going to get blood clots on your lungs. They're going to go to your brain.
Yeah, right.
You're going to get cancer, and it's going to metastasize and spread to your butthole. And now you're going to have painful poops. I just feel bad for everybody right now.
Yep.
Okay, so cirrhosis of the liver. What is cirrhosis of the liver? Just generally speaking, what is it?
Scar tissue.
Scar tissue of what?
Hard and
The liver.
small and ineffective.
There we go. So it's scarred, damaged tissues of the lungs. As those tissues become damaged, we lose what? What do we lose the ability to do?
So it can't take out toxins from your blood. We can't. The blood can't even flow through it, which is why you have the blood backing up into other veins.
That causes jaundice. Yep, that causes jaundice and stuff. We also lose those clotting factors, those coagulation factors, so we bleed really bad.
Yeah.
That's something I didn't get. I didn't get.
So the flow down. So the flow down, Sandra. And I think all of us have noticed this throughout the class. As we learn one system, as one thing happens, it's affecting other things. So as cardiac function diminishes, respiratory function diminishes, edema starts to happen in the other areas of the body not associated directly with heart, but the lack of blood flow from the heart. That's just one example, right? There's these follow-on things. The same is true with the liver. As the liver starts to stop functioning, all those other associated systems that we just learned about with some people drink too much, that's going to spill down and affect other things. So if we have diminished renal function, kidney function, is that going to affect our liver function? If our kidneys stop working, is that going to affect our liver?
Boy, yeah, it's going to kill us. It's going to affect everything.
It's what I like to call the death spiral. If our liver stops functioning, will it affect the kidneys? Yeah, and then we heard also, here's a question. If our liver starts to stop functioning, if our liver's damaged and it starts to die for whatever reason, what is it going to do to the spleen? This is a tough question. What's it going to do to the spleen if the liver starts to die?
Let's see. The spleen cleans or removes the old blood cells from the body.
And someone draw that line for me. If the liver starts to get damaged and it has a function that affects the spleen, and how does it affect the spleen and why?
I am not sure.
Okay, so look specifically back at the bile system. So bilirubin, it transports bilirubin, which is what?
The breakdown of blood cells, right?
So what does the spleen do?
It breaks down the blood cells.
There's an association right there. So if the spleen starts to get damaged, is that going to affect the liver? Yes, because those both have properties that break down old and damaged red blood cells. Okay, so if those two systems start to not function, how is that going to affect the bone marrow? You see where I'm going with that? The main issue there is red blood cells, right? If we start having damage to the liver, it's gonna affect the breakdown of old and damaged red blood cells. Well, the spleen does that too. And on the front end, the red blood cells are produced in the bone marrow. So does it make sense that that would spill over into those other systems because that one system stops working?
Yep.
Okay, that was it. That's all I wanted to do with that, was just kind of help us to get that higher level thinking that as the bone marrow starts to break down, it's going to affect the liver. It's going to affect the lungs. It's going to affect the kidneys. It's going to affect the spleen, because the bone marrow makes red blood cells.
And the red blood cells carry oxygen, so you start to suffer from hypoxia all around.
Anemia and anemia.
And all of the organs start to have problems.
Okay, so I think we got through We only missed like 3 more disease processes, 4 more disease processes. It is 9:30 or 10:30, so I'm logging off and going to work. You're all wonderful people.
Thank you so much.
Did anybody have any questions for the group before we log off and leave each other alone?
Nope.
Nope.
Okay.
I'm going to be prepared for class tomorrow. Thank you.
I just love.
Sandy, you had something you wanted to add? Sandra got cut off, but she loves everybody.
I'm good.
Lost you for a minute.
This is part of the tech problems. So Addison, you good?
Yep.
Dude, isn't it so much fun to go to work and actually have this happen?
Yes.
It's fun. It's awesome. Dude, medicine is so great. Okay, awesome. I'll be later.
Thank you, guys.
So tomorrow at 5 and 9:30 again. Come if you can. Don't come if you can. But I will have it on either way.
Okay,
awesome.
Thanks, Chris.
Okay, later. Have fun, ladies.
Bye.
Bye. Good night.